We'll get started. Thanks all for coming. My name's Tim Town. I don't know if you guys know who I am. I'm the Chief of Police here. I've worked here since 1989. Our focus tonight is the substance abuse issue that we're seeing here in Berwick. We have 4 speakers this evening, actually 5. We have Mike Wardrop, who's on the far end. He's the resident agent, U.S. Federal DEA, out of the Portland office. Then we have Dr. Lucas Colm from Wentworth Douglas Hospital. He is an emergency room specialist, I guess is how we'll refer to him. And we have Anna. She is a long-term person in recovery. She's talked to myself and some students that we'll talk about here in a moment, and we appreciate her coming and put her on the spot. We have Carrie Norton's a resident of Berwick, and Carrie is the founder of House on Havenhill, which is over in Rochester, and she works with expecting mothers who also have substance abuse issues. And then we have Dr. Mark Publicker, and he is works with people in recovery. He is out of Mercy Hospital in Portland. So what we're going to do this evening is each speaker is going to have, we're really soft here tonight, so 10 to 20 minutes. Really just give us an overview of what you see in your capacity with the opioid problem, excuse me. After everybody's done talking, there'll be time for you guys to ask questions if you'd like. I also would like to bring up a couple students. The way this came about was a class that I taught down at York County Community College on police community relations. And as the class unfolded, we had talked a little bit about the problems that Berwick was seeing on our area, Seacoast area, with substance abuse. So we kind of transitioned that into what you have tonight. But we'll start with Tiffany Norton. And Tiffany has done a great deal of work on this. She's actually the one that reached out and talked to the speakers that are here tonight. So Tiffany, if you'd come up for just a moment.
Good evening, everybody. Thank you so much for coming, and thank you to the speakers for taking time from your busy schedules as well. As you know, this is a huge issue. It's an ongoing issue. It's going to be a monumental challenge, and it's going to take everybody's effort to. It's not going to go away overnight, and it's not going to go away. It's not going to go away if we ignore it. It's going to take help from everybody. So hopefully tonight's goal is basically to educate, and to learn, and to reach out to those who maybe are a little indifferent to, or their understanding is maybe a little tainted, or they just, some of us don't want to understand. The easier thing is to probably ignore it or do nothing, but that isn't going to take care of the issue. So again, like Chief said, we're going to listen to all the speakers, and then if you would just hold off your questions until the end, that would be fantastic. We appreciate you coming tonight, and don't be afraid to ask speaker questions. I mean, really, don't be afraid. That's why they're here. So thank you very much, and enjoy.
What Chris was referring to is what I had done is broke down the amount of officers that I have on duty at one time, and it broke out to roughly have one officer on duty per every 2,600, almost 2,700 people. So if you really think about that in relation to the size of the town, like you said, we're only able to be, one or two places at a time. And so what we're looking for is help from the public to maybe move this problem maybe along, and maybe find some other solutions than what we're seeing right now. We're going to start, though, tonight, if Mike would come up and talk about the law enforcement side.
Thanks, Chief. As you indicate, my name is Mike Wardrop. I'm the resident agent in charge of U.S. drug enforcement here in the state of Maine. I'm based in Portland. I have an office in Bangor. We have a staff of special agents, task force officers from local police departments and sheriff's offices, intelligence research specialists, and support staff. And basically focused on the Controlled Substance Act, basically federal traffickers, high-level traffickers, which we identify through working with our state and local counterparts here in Maine. But again, Berwick's right on the border. We're fused to our neighbors at the south, New Hampshire, Massachusetts. You're going to see a lot of that in this presentation. This photo I have up here could be any town, any parent, any grandmother, any state. Unfortunately, that's the vivid image of what the challenges that we have as a nation right now with respect to this epidemic. So what defines a perfect storm? Two forces converging together. And I'm going to explain what I mean by this. So when you go back 5-6 years, oxycodones were everywhere, pills were everywhere, and we started clamping down on them, and we started clamping down on the pain clinics in Florida. We started engaging in the prescription monitoring programs. Multi-state here in Maine had a great program. We started talking amongst the programs and looking to basically eradicate those that were doctor shopping, those that were trading in their Maine driver's license and flying down to Florida and getting a script and then coming back here and selling it and getting on a 30-day cycle. And we were great at doing that, and everybody came together with law enforcement and the health community, and we restricted that. But what happened? Those that had a substance abuse disorder needed an opiate, and the closest opiate that they could then float to was heroin. Heroin has always been readily available on the market. Always been here in Maine, it's always been in big cities. We have Dominican trafficking organizations down in the Lawrence, Lowell, Methuen, Haverhill area that have been there for years, decades. They're second and third generation traffickers. They're not going away. Hopefully at some point they will. But again, they're at our doorstep. So the response, as I said, the prescription monitoring programs, DEA, we levied really large fines on big pharma. But again, that didn't stop it, and it got us into this crisis that we're in now. 2016, over 42,000 deaths. I mean, that's just a little insanity. I mean, you can read this for yourself. There is no jurisdictional line. There's no boundaries. You can't suppress it. It just free floats everywhere. So what I'm going to do in this presentation is I'm going to let a helium balloon go up about 25,000 feet, and I'm going to show you sort of with imagery. This isn't death by PowerPoint. This is imagery so you can better understand the world that we live in with federal law enforcement and how it actually flows here into Maine, and then it goes down through the stages of distribution and how it impacts everybody. So heroin, these are the 4 source areas for heroin. Predominantly what we were seeing in the United States, and we're not seeing as much heroin anymore because it's floated to fentanyl, and you'll see, is Colombian heroin, and now the Mexicans are producing white heroin as well. That's the largest intake. But what's impacting us now is China. China is selling the precursors for fentanyl, which is then being distributed to Mexico as the precursors for methamphetamine were. And the cartels, predominantly the Sinaloa cartel in Mexico, is producing it in covert labs and then using the same transportation networks, bringing it here into the States through the ports of entry. Through the ports of entry in the same venues that they were shipping cocaine, shipping methamphetamine across the country, whether it's going into California, coming through El Paso, and then making their way to the large hub areas of Chicago, New York, and then up into the New England area. So our target area is there, smack in the middle on the right side, Lawrence, Lowell. 2nd, 3rd, 4th generation Dominican families. It's a factory town. These families have been embedded there. They historically, 20 years ago, were the transportation component of Colombian cartel organizations. But then the Colombians were taking such a large profit hit from law enforcement that they got out of the business of distribution and transportation, and they just set up the factory down in Colombia, and they let the Mexicans and the Dominicans handle the distribution here stateside. So when you get into the larger level distribution in Massachusetts, which comes to here, how many have heard the term finger with respect to heroin and fentanyl? Some of you have, some of you haven't. I also want to point out, I want to thank the two students, younger students here, for showing up. That's really important, to really have this education and being committed to coming to a forum like this. That's huge, so thank you for coming tonight. So fingers, what the Dominicans do is each of those is 10 grams, and they create them in a setting what we call a mill. Mills could be in an apartment with kids in the back room. It could be a hotel room where you're coming in, your family coming to a weekend lacrosse tournament, and your families, and you just got done with the softball or whatever, you're in there getting to settle down, and right next door, these guys got masks on and booties and eyeglasses, and they're mass producing fentanyl for distribution here in the States. So these are coffee grinders. This is what they call the press. And what they do is they mix, they'll break down the kilo of fentanyl, which sells for about $60,000. And again, it's very high purity level. And they'll break it down, they'll add 9 times of another cutting agent. A lot of the lab tests that we've analyzed, a lot of it is mixed with acetaminophen in a powder. But the challenge is, one is powder form when you break it down, and one is granular form. So what they do is they mix those two, they put it in a little coffee grinder, like you use at home to grind your coffee beans. They zip it around, and then they start putting it in those little pistons, and they compress it. It comes out in that little, looks like a piece of chalk, and then they wrap it, and that's your finger. And they'll put them into sets of 20 for distribution. If you're buying one, if you're going down there, it may cost you $400 or $500. If you're buying 10, 20, or 30, it could be as low as $200. But the profit margin, now you bring it into Maine. I just reviewed a report of a trafficker from Waterbury, Connecticut, distributing up in Washington County, purchasing in Lawrence. He's buying it down there for $300 a finger. He's selling it for $1,800 a finger outside of Calais. Just the profit margin is massive. But again, when I talk about mixing of the granular substance and the powder substance, it doesn't mix. So once it's distributed and broken down, that's the challenge. You're basically playing Russian roulette as somebody that's going to abuse that substance, because that granular, the fentanyl, is it in the corner of the bag? Is it not in the bag? Or did you get the larger portion of it, and then you're going to go into cardiac arrest? That's the big problem. So when you look at fentanyl, the potencies of it, 80 to 100 times the potency of morphine with respect to heroin. Visual, again, how much heroin, how much fentanyl. It's just granular. Pharmaceutical grade fentanyl, 1 grain on your finger through absorption can kill you. With DEA, we carry naloxone, Narcan, not to be first responders, but we come into contact with these substances, and God forbid one of us falls, we want to be able to bring them back immediately. Again, it's fentanyl is measured in a microgram. It's such a small portion. The overdose deaths around the nation, the Mexicans have totally transitioned to distributing fentanyl. There's not as much heroin coming here. In fact, and I correct the media many times over, is you always hear heroin mixed with fentanyl. That's bad news. That's fake news. It's fentanyl mixed with other substances. There is no heroin in the state. Everything is fentanyl. And people that are buying this stuff need to realize that you're playing Russian roulette, because you do not know what portion of the bag was from the kilo of the pure stuff or part of the acetaminophen on the other 9 parts. Again, another visual. That's a quarter. Can you see that grain on the right side? You can't even see it. That's how small it is. Again, if you get that one little portion, it'll kill you. I mentioned it's predominantly Sinaloa cartel. We, successfully working with our Mexican national counterparts, have seized a couple of fentanyl labs down in Mexico that were producing multi-kilogram amounts. Recently, DEA did an enforcement operation in Massachusetts, in Lawrence, that really decimated a predominant Dominican organization distributing just hundreds of customers coming from the northern states to Massachusetts weekly. It was insane. Yet the organization, they're decimated, it didn't even blink an eye. The other organizations just pitched right in, filled the void. So it's nonstop. How long has fentanyl been here? October of 2014. It's been here for 3.5 years. That's the first large seizure. Probably some of this was destined for here because it's just up the street. This gentleman in Sanford was getting it in Lawrence from Dominican organizations and distributing it in the northern York County, central York County area. So we've seen it for a long time. The other challenge is in Canada, they're counterfeiting fentanyl. So using it, in this instance, making Canadian oxys. And you think they're taking an oxycodone, in fact, it's fentanyl. And we've seen it on stateside, we've seen it in Canada. It's scary. It's really scary stuff. Again, there's no quality control, there's no quality assurance. They're just bringing this stuff over. And then the elephant in the room, carfentanil. There was 4, possibly 5 overdose deaths attributed to carfentanil here in York County. The background behind this was a trafficker in Manchester, New Hampshire, who hired a buddy who was an IT fanatic, who knew how to maneuver the dark web, and he started purchasing carfentanil from a source over the dark web in China, shipped to Manchester, broken down, and started distributing it. Well, you're not that far from Manchester, and they were bringing it over to here, and that's why those overdose deaths occurred in this region. And the people who were abusing the substance knew that it was great, they were getting a great high, and they were purposely looking for that bag that was being distributed. And when they ran out, they basically would just wait, and they would ask, when is it coming back, when is it coming back? And finally it would come back. Again, you want to compare heroin, then fentanyl. That photo on the top right was courtesy of the New Hampshire State Lab. They actually broke down the substances so we can have a visual of, how damaging is this stuff? How much do you really need? What does it look like? And it's, you break a little salt pack and you break it down. It's just that little grain. It's not a lot. What feeds the frenzy here in Maine? We have the warehouse right down the street. So we don't need large organizations based here in Maine because everybody could day trip. People in this area can be down in Haverhill, Lawrence in 45 minutes, 50 minutes, picking up 10 fingers, bringing them back, keeping 3 to support them medically, and then selling the rest to pay for their bills. And that's back and forth, back and forth. So again, it's building the information that we need to eradicate those different issues and the challenges. While we're down there, we took this picture. The impaired driver beside of it is, these people are, when they're going down there to purchase, they're going to get sick. And so as soon as they do that turnaround, they're on the side of the road with needles, injecting, and then they're driving back. But they're all impaired at that point. Obviously, they're getting better. But again, we're dealing with a lot of impaired drivers, which is really a safety issue for any parent coming up in a minivan with a vehicle full of kids. I mentioned the Narcan and naloxone. Again, we carry it. A lot of departments are starting to carry it. When you come to the arena of Augusta, it's still suppressed for whatever reason. I still remember sitting in a room with the governor, and he said, are we saving lives, or are we just waiting out death? And it's like, really? You need to put that option out there. Tell that to a parent who has hope that their child at some point will get through it, or their husband will get through the sickness. So when we, several years back, 3 years ago, when this started really hitting us hard in 2015, 2016, we had to come up with some creative measures. And we need to learn from this stuff. Because we noticed that a lot of this information was stovepiped. There might be 3 overdoses in Berwick, and then a couple would pop up in Sanford, and a couple would pop up in Biddeford. But nobody talked, and we wouldn't figure out what happened until 10 days later. And it was insane. So we came up with these quick cards that we sent out about 6,000 around statewide to all police departments, some EMS, some fire departments. It was a quick sheet for the officer on scene to gather information and distribute it so we can analyze it and try to figure out, put the puzzle together and try to work through it. Because when, historically somebody passes away from, abuse of heroin, they go to the local morgue. I mean, say it that way, but that's all they did. It's a homicide case. Somebody supplied them, somebody's responsible, somebody should go to prison for what they did to that person. Somebody needs to pay the penalty, be responsible. And that's what this is for, is to learn from it. And then obviously, breaking off from this a little bit, other creative measures. Berwick has been a long-term supporter of the drug take-back program, along with most other agencies here in the state of Maine. We just did this a week and a half ago. We collected 28,000 plus pounds here in the state. But again, since 2010, almost 350,000 pounds of medications that people were disposing of. A lot of meds, but again, it's a great measure. People are getting it out of the house. People aren't breaking into homes. It's working out. I'm coming near conclusion. Leveraging resources. There's a lot of resources in this room here. You know, some of you I've met before. I did a presentation at the college. There are great resources. They're coming up with some really creative ideas, putting a program together to benefit the community of Berwick. You know, a resource such as using signage to really get the measures out, marketed. If there's local business that have signage that every once in a while, they'll give you a Wednesday afternoon to put up a creative message. It's important to be able to use all those different mechanisms at your whim. And this is my last slide, but third to last slide, but an important one, is destigmatize recovery. We need to talk differently. I'm only going to say the word once, is the A word, addiction. All right, strike it. You won't hear me say it again. Substance use disorder. We always use that A word. Those in recovery that are trying to get better, they're going to create, it's going to be a negative, and you're just not going to get through to the people. They're not going to trust you. And it's really important to start really learning new language and engaging people that are in recovery or want to become in recovery. A lot of the people that provide us information in law enforcement aren't in recovery yet. We want to get them over the hurdle into recovery. The fact that they're with us is because they probably had 5 or 10 fingers in their pocketbook and you know, they're in a bad situation. But again, they have those 5 or 10 fingers because think of the worst flu that you ever had and you would do anything to make it go away. A person that needs that opiate fix is feeling the same way, and they'll do anything to get better, which is why they travel down to Lawrence to get better, because then they're functional again, and they can get through the day. But then the cycle comes to conclusion again, and they have to do it again. And we have to find the means to get out of that cycle. We need to create the treatment programs. We need to think outside the box. So many people are compressed inside the box, and this is how we've done it for 20 years. I hate it. I hate that when they say, you need to step out of the box, get real smart people together, think of creative ideas, and then get back on the horse and travel forward and create programs and create a mission and goals. It's truly important. Again, well done is better than well said. Well said is us talking here, but well done is you're creating a program for this community, and you're going to move it forward, you're going to be goal-oriented, and you're going to get some stuff done, and it's going to be better for this community. So I applaud you for your efforts. And that's my conclusion. We can hash down any questions for afterwards. We're going to keep the flow. This thing's moving over. Thank you.
One thing I should have said in the beginning, although the crowd here isn't huge tonight, it is being televised, so the entire community of Berwick is able to see this. It will be aired several times after this evening, and I want to thank Terry Wright for coming out. She runs Berwick Community Television, and she's in the back of the room here filming for us. So again, although the class size here today or the size of this group is not huge, it's being broadcast to the entire community. So with that, if Dr. Cohn would come up and take a few minutes.
I wish he had not said it was being broadcast. I said over and over again to the whole community of Berwick. But
Be like 7,500 people.
7.5 people, that's what I heard. Anyway, I know some faces in here over a long period of time and whatnot. My first name is Lucas Colm. I'm an emergency medicine physician. I work over at Wentworth Douglas Hospital. I've been there for several years, since '01 actually. And kind of a good segue coming out from where Mike was talking. It's kind of going to go backwards for me based on, rather than just talking about true tales from the emergency department and cases, and I can certainly kind of conclude with some examples that stick with me, recent cases and ones going back over my time before I ever knew that I wanted to pursue medicine in a career that affected my personal life. And then, just watching the evolution of what's going on now in our area. So picking up where you were talking about addiction and not using the A word, it's so funny because, you want to put into practice what we know using the Tom Brady slide, but we all get caught, and I'll speak for myself, that our lives are busy, and the A word can become so much a part of my daily life professionally, and you're exhausted with people who are addicted and who have substance use disorders, that you get caught almost having to remind yourself to not be judgmental. And that's from a healthcare professional. It's from other people who truly are compassionate, who truly want the best for every person who comes in looking for resources as it relates to substance use disorders. But sometimes you have to remind yourself of what your inside voice is. You have to remind yourself that maybe you're focused, even though you don't use the word addiction, you're kind of coming from a mindset of, oh, it's just an addict, it's a junkie. All the other words and verbiage that we come to. And what it does is becomes a barrier for trying to reach out to these people who are in need. And then I have to remind myself, and I've said this in the past, that what's the difference for people who seemingly can't get out of their own way as it relates to substance use disorders, for those who can't get out of the way of managing their chronic illnesses and their diseases, which are genetic predispositions. And you can start talking about what does that mean. I'm talking about diabetes, I'm talking about eating disorders, chronic smoking, and there's no component of how to stop that kind of substance use disorder. And also don't forget about alcohol. And alcoholism crushes every other substance use disorder by 100-fold across the planet, and we also label those folks. And so kind of coming from that lens, and what we deal with is that as law enforcement and everybody else has really kind of come into their own with how we're going to get awareness out to people as soon as elementary school, to be aware of people in their families and identifying friends and their own issues, and how to bring that awareness closer to resources that are already scarce to try to get help and to stop the worst outcomes, which is death or unintended consequences and injuries that will change people's lives forever and always. Because there just isn't enough law enforcement, as we talked about. If there's one officer for 1,000 people per populace, the real help is about intervention, identification, and resourcing help. But I think what we have to realize is that we're never going to eradicate or get rid of addiction or substance use disorders. This country is only a few hundred years old, and substance use disorders have devastated and wiped out cultures that were thousands of years old. And substance abuse, whether it's illicit, meaning legal prescriptive drugs, or substances versus illicit or illegal drugs, are abused in all different ways. And we will never, I'll be that presumptuous, say, we will never outrun this. So it's a matter of how we wrangle with it and how we move forward with the people that are closest to us. And whoever said it takes a community, it takes a village, it takes a country, and it takes a global initiative in different ways to get control and to make it safer for the people who are at the greatest risk. Putting a divide between what was presented is the fascinating part for me, because what you are tasked to, and all of your colleagues and all of us, is big business. That's like global multi-billion-dollar industry, which is fascinating. You're trying to stop trafficking networks, chemistry experimenters who are taking fentanyl, which in the medical world is a controlled drug that's not in a powder, that's not cut 9-to-1. It's used primarily in patients who have such bad pain that morphine won't correct it, like who? Cancer patients, patients who have horrible bone pain and other issues that just can never get comfortable. And it's used in very small concentrations, and not to control their pain for days, but over time, and while they use other modalities. When you hear fentanyl being synthesized in these labs, manufactured, they're basically finding every which way to take whatever, $60,000 worth of a drug and then monetize it in 3, 4, 5 times a margin, which is business. And not getting too far down the history of this, Big Pharma, as we know, multi-billion-dollar industry, pushed forward the necessary way to manage pain, keeping away from drug cartels in the early 2000s, for those of you who haven't read about it or heard about it, where there was something called the fifth vital sign, and the fifth vital sign was pain. And if you, meaning me or anybody in this room who's attached to healthcare, didn't manage the fifth vital sign with appropriate pain management, like opioids or opiates, so narcotics, we would be potentially found at fault of not doing the right thing for our patients. And not to get into the whole thing about vital signs, pain is not a vital sign. A vital sign is your breathing rate, your respiratory rate, your pulse, your blood pressure, temperature. So it was a misdirection, if you will, and it went on for many years. And what happened as that came forward was Big Pharma came out in the most logistic, illicit way of creating a whole bunch of pain meds that were then attached to me having to manage the fifth vital sign. So then there's a lag period for prescribers and the whole kind of art of medicine and the prescribing practice of medicine to start ramping up with that, necessarily in some ways. But then it accelerated what we then found from the medicine side of things, where all of these deaths and unintended consequences were attached to the flourishing opiate market. Opioids everywhere, prescribing practices, and then what you were talking about, which is huge, is that too became monetized in sort of a legal and then illegal way. You had people who had medical licenses opening up pain clinics that weren't regulated, and then it became even a little bit more loosey-goosey for people who said, I'm going to manage your pain, and I don't want to have to worry about knowing what behaviors started to become as it relates to substance use disorders. And so more and more prescriptions are being put out there for dozens and dozens of pills where you only needed to have maybe 6 pills. You're getting 60 pills. So you're going down two different paths. You have street use and street synthesis, and then you have this whole legal side of production and prescriptions and whatnot that is facilitating more substance use disorders. So then we come back to substance use disorders. What is there out there for to deal with the people around us? So before I went into medicine, I grew up in Boston. I wound up in a public health program, and I was introduced to some people who were trying to legalize needle exchange in the Boston area, because the addiction issue was so crazy and people are dropping dead, and also disseminating disease, HIV, STDs, hepatitis C, and there was this big push because it had already been proven to be very effective in reducing diseases. So people aren't getting as sick. And if there's any hope for you to get off of whatever substance use disorder you have and get help, hopefully you don't find out after the fact that you're terminally ill because you contracted a disease from desperate use of dirty works or syringes. And there's been so much stigma with that over the decades that why would I give somebody clean needles? Why would I make it easier for them to have access to the use of apparatus that aids and abets their drug habit? And the truth has been proven over and over again statistically that it doesn't do anything other than give people an opportunity to stay healthier, avoid adverse behaviors in looking for those apparatus or syringes, and still trying to deliver them an opportunity to get to recovery. And that's really where I think all of us have an opportunity now in the community, where there's a lack of resources, but there's not a lack of a village that's being ravaged by people overdosing. And it's about us having our eyes open and being willing to say, how do we help each other? How do we listen? And don't tell people what they should do. Don't tell people what they want. Don't tell people what they need. We have to ask people what they want. You have to be patient for that, and ask them also where they might potentially consider even going for help. And then is there a possibility of getting them there? And when people say they don't want help anymore, or they bail on it, like they'll walk out of the emergency department after a near-death experience or a real death experience, and they're fortunate enough that they, 2 hours later are ready to leave. The real offering to those people, all of us, is whenever you're ready to come back for help, you can come back anytime. It's not that if you leave, you're done, because that was like kind of a retrospective, traditional way. It's like, you need this, you're going to get this. If you don't take it and you don't adhere to it, you're done. And that's just a failing prophecy for all of us. And so I just encourage people who have people that are next to them. I mean, we can always do the survey. How many people in the room know somebody or encountered an incident? Every time I go anywhere, it's every other person either knows somebody directly or somebody else is attached to that person who has an issue. And so it's going to be embedded in our lives. And if it hasn't embedded your life or it touched your life yet, I promise you it will. So personal stories, the face of addiction is you looking in the mirror And that's what we have to remember. If it's not you, it's your girlfriend. If it's not, it's your boyfriend. If it's not, it's your sister. If it's not, it's the quarterback. If it's not the quarterback, it's your fellow DEA agent. If it's not, it's my fellow colleague who's a cardiologist. You know, it's anybody and everywhere. And until you accept that, we miss it. And then we become judges, and then we become stuck on, I can't help you, or you think it's not until it's in my backyard. Example after example. I lost a girlfriend to addiction. She had a very tough time with alcohol, and then it spilled over into polysubstance use. To kind of be a little bit divergent but consistent, when you're talking about a fentanyl cut of 9-to-1 and that acetaminophen, aka Tylenol, versus the little speck on that slide, polysubstance abuse. I see more people who come in and it's not just an opiate, it's some other substance they're using. So they're speedballing, they're doing other things, and you're trying to catch up with who knows what they're taking. And when you talk about the synthetics, when it comes down to it, you mentioned carfentanil with slide with the elephant tranquilizer. Then there's W18, which is 10,000 times stronger than morphine, and carfentanil is 100 times stronger than fentanyl. So, I mean, you could be making your final transaction and sealing a deal, like you said, unfortunately carry Narcan or naloxone. And if that one spec doesn't happen to just be fentanyl, and it is one of those other substances, there isn't enough Narcan in probably a pharmacy of a hospital unless you start pumping it into somebody IV to reverse that drug. And that's why firefighters, law enforcement, or any of us who say, hey, what's that white powder in your trunk or whatnot, you don't know what you're getting into, and you may not be able to reverse that. So the cuts that we're seeing now in this world of fentanyl sometimes are purely driven, in the word purely, for the monetary component. Real life story, old-time heroin addicts who have been shooting heroin for decades, both of them in their mid-60s, completely comatose, coming to the ED, and they were really, really upset, not with their near-death experience, with their dealer, because it was the same dealer who they could trust like a relative, because they have full-time jobs, these guys have retirement accounts, they just happen to be lifelong heroin users, but they were left for dead because they got a cut that they didn't know from a dealer they had for years. And it's a changed world for those who are experienced professional substance use disorder people, if you want to call it that, versus other people who just get stuck for a multitude of reasons of why they become substance abuse or addict trapped, if you will. And it's a continuum. Some people use substances because they're bored. Some people use it because there's mental illness. They're domestic violence survivors. They're managing their own pain. There's a whole myriad, but the continuum goes from abstinence to, hey, you want to try something? It could be just a Percocet, or they got hooked on the prescription, so they're experimenting with a little bit, and they reach out, and you can get heroin cheaper than a cup of coffee. You go to Starbucks, get a bag of heroin, fentanyl, cheaper than coffee. And, you know, don't put your hand in the trash at most Dunkin' Donuts, because it will look like the slide with the needles that are, and then you'll come out with a needle stick. And then you go to the continuum of chronic use, and then the use becomes scattered. You're desperate, and that's substance use disorder. People will do anything. Another real-life story, my friend's brother calling me up when I was a medical student in the middle of the night, hey, you want to buy a fish tank? I'm like, it's 2 a.m, I don't want to buy a fish tank, because it's the wrong time, and I have no idea why you're calling me. Next thing, how about buying my parents' silverware? It's these acts of desperation so they could score more heroin. And I'm sure people know how this goes with anybody you may have either seen or heard about. But the problem is peer-to-peer compassion and peer-to-peer direction in order to keep people from dying. In a class that was involving law enforcement, emergency medicine, paramedics, firefighters, the question was put out, if you had the same 17-year-old girl who had overdosed on her 5th time, and you'd been dispatched to their home again and had to revive her, when you get the 6th call, how many in the room would go back and be willing and really like as diligent and willing to resuscitate that person? There must have been 30% of the room that was like, I'm not going back. I'm not doing it again. And I found that to be fascinating in a kind of troubling way. And this was with people who are just starting out in the career, some are middle ground, and others who have been doing it forever. And the common reason why people would say they wouldn't do it is because that person needed to learn their lesson. But what's the lesson? It's death. So you're basically saying that at some point you're exhausted. This is where I started the whole part about use the A word or not. You get so burned out and you don't know what to do, and there's nowhere for these folks to go on any regular basis, particularly if they haven't had coaching, peer-to-peer, and somebody to really reach out to, let alone other resources, that it's just the same thing over again. They get to a point where they're never going to do it again, or they're clear-headed enough, they overdose, and if it's a bad cut and they're using alone, they wind up in that situation. And I think that's where we all have to kind of, if you get to a point where you don't know how to deal with it, you have to find other folks who can help you help the people in your world, because that's really where we're going to take the community, village, nation approach, because it's not just hoping that you can call law enforcement or get somebody into a place. And a lot of people still see that as punitive. And there have been laws that have been passed in New Hampshire and other states that have, first of all, thankfully, recently in New Hampshire, pushed legal needle exchange, which was a forever and always push to get that through. But then there is the anonymity rulings, which allow people to say, I think something really bad is going on, and I don't want to call the police because I don't want my brother and everybody to go to jail. But if it's not like a kilo sitting on the coffee table with an intent to deal, police will come in, and they will help bring medical aid and resuscitative measures to save somebody's life, and not just focus on how everybody is going to be, caught in a whole world of hate because there's illicit substances on the table, barring, trafficking issues and whatnot. And then I think that the other part is don't underestimate anybody or any circumstance that involves substance use disorder, because that's where the new push on what is happening in the emergency department over the last couple of years has really been an eye-opener. And what I mean by that is we see so many more people that have overdosed, and we don't know what to do with them when we've resuscitated them and they're back in a good state of mind, so to speak, they're clear-headed, because they don't want to stay. You can't keep people against their will. And I have seen more people in the last 5 years of my practice that within not just days, but hours, have overdosed again and or died. And if you're a physician in a high-risk place like an emergency department, it is a very disturbing circumstance when your patient leaves the emergency department at 8 a.m. and they're dead at 1 p.m. Or the patient that I've seen since, not that I'm a general practitioner, but I've seen some people that I've watched them grow up. And I know that they've had issues in all different arenas, and they'll explain to me that they're doing their best, and they know they're in trouble, or they know that they're not going to outrun it. And we did everything we could. And some of these folks we even have had in the department have brought resources to for day after day after day, and they go home, and I find out that the subsequent day they overdosed and they didn't survive. And this has never really been that part of the addiction or substance use disorder phenomenon. This is a whole nother level. It's a medical legal concern for practitioners for sure, because you don't know what to do. You can't lock people up against their will. But there's a huge likelihood today that people who have this level of substance use issue without getting resources or other ways to get into any kind of outpatient rehab, let alone inpatient, their risk of dying is far greater than it ever has. And it's because of accessibility and also what they're using. Does any of that resonate or ring true with some of the stuff that's going on in the world of, Berwick or any place else? That Narcan was another thing, legalizing Narcan as naloxone. Before, dirt cheap, shelf life, years. Finally, it gets legalized, and third-party prescription was mobilized or made available. Third-party prescription means you come in and you say, hey, listen, it's not for me, it's for my cousin. And I'm like, prescription for the cousin, no problem. Or you can walk in someplace and get it through a pharmacy because it's necessary, as it should be, for anybody who could potentially overdose, particularly if you're with them and you could save their life, or they have the wherewithal to give it to themselves because they feel like they're going to fade and not be able to save their own life. And as soon as that happened, not to go back to big pharma and whatnot, what happened to the price of Narcan? 4, 5, 6 times. So now it's this huge, money-making drug And, it's much harder to make it that much more available to whatever extent. But this is what goes on, It's a supply and demand circumstance, and it's attached to this ever-evolving, that will never go away issue of human nature, that we will use substances legally and illegally in the wrong way forever and always. Questions? At the end. All right.
Thank you very much. That was fascinating to see how you perceive that from your point of view. I was very curious to hear what you had to say, and I found that very, very fascinating. I'm going to try and get back on track with our agenda, so I'll have Dr. Publica come up at this point.
Whatever allergy is down here at Sydney. I just wanted to start by saying that I really agreed with Mike's presentation, but with one exception. The A word is not addiction. The A word is addict. I'm the former president of the New England Society of Addiction Medicine. I am a member of the American Society of Addiction Medicine. Addiction defines a disease. Addict defines a person. So we shouldn't back away from using addiction. Addiction is a term that defines the disorder. Saying a use disorder fails to really recognize the compulsivity, the demand, the loss of control that characterizes addiction. A patient of mine who, for example, drinks heavily has an alcohol use disorder, but isn't somebody who's going into acute alcohol withdrawal. So first little piece on that. Secondly, I always forget to ask if there's going to be PowerPoint. I felt so cheated, Mike, when I saw you had PowerPoint, because I have to do this without definitions. So let me start with the definition of addiction. Addiction is a chronic brain disorder that affects memory, learning, and motivation. And the brain circuits that drive those three basic elements. So we have to think about addiction as a brain disorder, that is to say, there is a neurobiology, that is the way in which the brain functions is disrupted, is hijacked effectively by drugs of abuse. So let me see if I can back up a little bit. I've got 15 minutes to explain all of neurobiology of addiction. So let's start by understanding that all animals, and that includes us, are designed to have a neural circuitry of reward. That is to say, there is a part of our brain that is designed to give us pleasure, to be able to reward us for engaging in behaviors that are inherently necessary for survival. So what does nature give us to have? Why does nature give us pleasure? We have to have pleasure to eat food. We have to derive pleasure from drinking liquids. We have to have pleasure from caring for our children and sleeping. So nature has given us a biological mechanism, a whole circuitry, a whole pathway, and neurochemicals that allow us to experience pleasure when we engage in behaviors that are inherently necessary for survival. So, core concept, drugs of addiction hijack this neural circuitry of pleasure and instead give the brain the message that instead of eating, drinking, sleeping, caring for one's children, in order to survive, one has to pursue this drug. So begin by understanding we're talking about circuitry of pleasure. Pleasure is necessary. Drugs of abuse hijack the center, and the intensely powerful stimulation of this receptor system far outweighs the pleasure that might be received from engaging in eating or drinking. Let me see if I can explain this. It usually falls, so nobody gets it. I know how to fall. Here's addiction. I could probably stop after showing this. We are all designed to have a normal range of pleasure and reward. Different ones of us have different ranges, but the brain wants to defend this. So let's say this is a normal range from here to here. So this is what nature wants me to experience. This is all of my pleasure, all of my reward, my mood state. This part of it is more in the negative state. This side is the happier state. And we can have something really catastrophic happen to us and have our mood go deeply into the negative territory. But our brain is designed with these mechanisms that want to keep us in the healthy zone that promotes survival. So even if something terrible happens, we may go into the negative zone. I may be driving home and I'm speeding through Berwick, and I'm hoping that, the Berwick police are going to be accepting of this, but I see the flashing lights in back of me. What happens to my reward center? Well, my reward center has gone down here. However, by the time I get home, presumably I'm back into my normal mood state, unless I have to explain to my wife that I just got a ticket. On the other hand, if I win a lottery, I win a big lottery, I win $50,000, and you move outside of the range of normal pleasure that we're supposed to experience. However, research has really shown that really great rewards, you win a lottery, look at somebody 6 months later, they're not experience this tremendous sense of joy. For the most part, they wind up back in their normal range. Now, I think that there's an exception. I'm pretty sure if I won $1 million lottery, I'm probably staying over here. But for most people, we're going to be moving back into this zone. So I want you to picture that now. Neural circuitry reward. It gives us pleasure. We're supposed to live within this range. Now, I have got a granddaughter who her range is here. I don't know where she got this range from, because nobody in my family feels this way. But her negative range is higher than any of our best ranges. But, mine, I'm kind of a grumpy guy, so I'm kind of here. Now, the first time somebody uses a drug like fentanyl, like cocaine, an initial response takes me completely outside the range of normal human experience. My state of pleasure is all the way over here. This is inconceivable for those of us who have not experienced cocaine use or have not used an opiate. So I have experienced something completely outside the range of what might otherwise be experienced. We were not evolved to experience that. However, as I explained, the brain has got neuroadaptive mechanisms, actually has powerful mechanisms that want us to be here because this is survival. The problem is we didn't evolve with cocaine. So that adaptive mechanism overshoots. So at the end of the cycle of use, I'm here now. This is in a negative territory. I experienced that. Now I am here. So what is the natural thing to do? That was fantastic. So I'm going to go back and I'm going to use again. But what happens is progressively the brain changes. This is an important concept. The more one uses, the more frequently one uses, the way the brain changes is it progressively doesn't allow me to experience that state of pleasure. So I move here, my hole gets deeper. I'm not feeling as well here. So I'm using again, and eventually I reach a point where I'm no longer able to experience the positive reinforcing effect of the drug. However, this constant adaptation pulls me deeper and deeper and deeper into a hole. So let's imagine this for a second. So we're talking about you use a drug, it's powerful, takes us out of the range of normal human experience. Experience pleasure. The worse you feel, what do? Use more. And if that doesn't work, you start combining. Speedballing. So initially, opiates are giving you the pleasure. So when you start losing that, what do? Well, you add cocaine to the heroin. The problem is the more that you use in the backside, that neuroadaptive backside, the worse you become. This is not capable. You can't survive here. This is physical, emotional, spiritual pain. It's unbearable. Mike was describing that. It's exactly right. You will do at this point anything in an attempt to escape this pain. That's addiction. When you speak with people who are opiate addicted, The worst part of opiate addiction that they will tell you is waking up in the morning and having to search. The worst thing in the morning, and it's the thing which will often drive people to seek help, having to wake up in the morning, having to find medicine, having to find drugs, having to find money to support your habit, to prevent you from getting sick, completely dominates your life, eventually becomes unbearable. So addiction, positive reinforcement initially drives the addiction. The pleasure principle at the beginning is what sustains the addiction, but eventually it's the negative reinforcer. It's the negative state of mood, physical state, with physical withdrawal, as Mike was saying, is just unbelievably, unbearably painful. Spiritual emptiness, progressive social isolation from family, from friends, progressive losses in one's life. So that's addiction. Addiction, neuroadaptation. I'll say the phrase, it's going to be not helpful to anybody, but I always love using it. It's called counteradaptive hedonic dysregulation. I just like to say it. But now, how does, I guess one of the things that we can talk about briefly now, the other thing which I always feel cheated about is I always forget when they say 15 minutes for a talk. Everybody goes before me, always goes for a half hour. So I'm behind the ball right now. How do people become addicted? First, about 50% of addiction is felt to be genetically related. Simply having genetic loading, however, doesn't predict that you're going to develop the disease. You can have the genes for diabetes, but not have diabetes express itself. If you're following diet, exercise, you may never know that you were diabetic. Well, the same thing is true with addiction. We all know people whose family members had been drug addicted, strong family history of addiction, yet addiction doesn't express itself in their lives. But starting out with 50% genetic loading. Secondly, it turns out genes by themselves, as I say, don't cause you, don't require that you will develop the disease. External factors lead to the expression of the gene. What are external factors? Abuse. In my practice, and I think everybody's practicing addiction, probably 70%, 80% of the young women that we treat have been sexually abused in childhood. When people ask me what is the best way to prevent drug addiction, I say, let's find a way to stop child abuse, child sexual molestation. Because honestly, that's where it's starting. So it's sexual abuse, physical abuse, emotional abuse, neglect. All of these have powerful effects on the brain. We're not even talking psychological effects here. We're talking about changes in somebody's reactivity to stress. So stressful circumstances that other people might not find destabilizing that cause them to have decreased ability to function, to be able to cope with life. People who have grown up with states of harm, of malnutrition, of neglect, of abuse, actually have this hyperreactivity to stress. If you have a hyperreactivity to stress, and you have genetic loading for drug addiction, and you've begun your drug use early, because that's the other factor. The earlier drug use occurs developmentally, the brain is more vulnerable. So children who begin their alcohol or drug use in their early teens are likely to develop brain changes that will predict lifelong problems with substance abuse. Not uncommon in my practice to have patients who tell me that they started drinking at age 9, 10, or 11, began using opiates at 11, 12, or 13. Earlier they begin use, the later, the more likely it is they'll continue to have a problem. People are saying marijuana isn't the gateway drug. Yes, why? I have virtually no patients who didn't start their drug addiction with cannabis. I just want to say cannabis is so ubiquitous in the state, that is, it's all over that. If I get a urine drug screen without marijuana, I'm pretty sure I've got an adulterated urine. I don't think it's the patient's urine exactly. So we talked about, and then let's talk about other factors that may predispose to addiction. Let's talk about mental illness. Anything which is going to affect the brain's ability to regulate mood, regulate thinking, is going to put somebody at enhanced risk of developing some type of an addiction, some type of substance use disorder. I'm trying to jam a lot of stuff in here, but let's just say a couple more things. There are two parts of our brain, to simplify that. There's a lower, evolutionarily earlier part of our brain. It's a part of the brain that gives us drives, it helps provide us with pleasure, it regulates our physical systems, it produces hormones. In adolescence, it turns on and it produces tremendous drive states toward sensation seeking, toward novelty seeking. Very, very powerful, but the part of the brain, and it sits in back of the eye, it's called the prefrontal cortex. This part of the brain is responsible for something that's called executive function. What's executive function? It's thinking, it's planning, it's reasoning, it's assigning values to things, it's error checking, it's anticipating consequences of behavior, it's the ability to inhibit harmful impulses that are arising from lower parts of the brain. Well, I don't know, I'm afraid there's probably 14-year-olds in the brain. No? Okay. Yes. The problem with adolescence is that if you think about a child until 8, 9, 10 years of age, the child's personality is pretty much steady. 8-year-olds are great, especially 8-year-old girls. I just think that I have a 9-year-old granddaughter. They're very, very stable. What happens around puberty? Well, physiologically, the brain explodes. Suddenly, there are billions and billions and billions of new nervous system connections, and that creates chaos. A child who had a very clear sense of identity, who had the ability to inhibit harmful impulses, who was responsible, suddenly is in this terrible mess, because things that the child knew about who she was, what her relationship with the world is, how to restrain harmful impulses that are charging up. It's the GO system that's welling up. It's at that point that the vulnerability for the development of substance abuse disorders is greatest. So we have to understand that there's developmental issues involved in developing addiction. So we try to tie together neurobiology, we try to tie together what is the nature of what's happening and driving the development and sustaining of addiction, what are the factors that are likely to explain how addictions develop. Obviously, we're talking about a very complex situation with neurotransmitter systems that, obviously, for the interest of sanity, I'm not going to go into. Okay. There is a treatment. Because we haven't talked about treatment yet. We're talking about a brain disease. We're talking about a brain disorder. We have a very, very, very good understanding of the underlying biological mechanisms that drive addictions and give us appropriate targets for treating addiction. And there are very effective medications for addiction right now. I'll just mention the medicine for alcohol, because nobody thinks that alcohol has effective treatment, so there are, and I'll just put in a plug for that, because alcoholism has been orphaned by the opiate epidemic, so there's very little alcohol treatment available. But medications for for opiate dependence, including buprenorphine, methadone, and naltrexone, are effective, are readily available. I say readily available because in Maine, we don't have universal health insurance, and that limits access to care. We have a limited number of doctors and others who are able to prescribe buprenorphine. However, it works. It's a miracle that somebody really wants help. Now, as far as Lucas, I just want to make the point. More and more now, and it just started in Maine, administering buprenorphine prior to discharging a patient who has overdosed and giving the person buprenorphine prescription to tide them over and to make connections into the community is life-saving. It makes a lot of sense for somebody who's come in a drug overdose, who is sick at that point, to go out and want to use again. So we shouldn't be surprised that people are going to do this over and over. Treatment will stop that. So what's the answer in this regard? The answer is treatment. What's the treatment? It's medication-assisted treatment. That other treatments are helpful perhaps for some individuals, but we're in the midst of a crisis that is so severe, the average life expectancy in this country has decreased. So we can't let ideology get in our way or beliefs get in the way. There's medications that are effective. They are consistent with going to 12-step recovery, being in intensive outpatient treatment. These are not mutually exclusive, and we ought to be able to make use of them and understand how important they are. So, did I do 10, 15? Did I hit 15? I got 15. Okay, I'll stop.
Gary, if you don't mind coming up?
Yeah.
And if you don't mind, when you're done, if you want to.
Hi there, my name is Carrie Norton, and I am a family member in recovery. What that means to me is that my life and my family's life was nearly destroyed by substance use disorder, and it was restored by recovery. I'm a lifetime, I've been raised, I was raised in Berwick. This was my school, my elementary school, and I raised I have three adult children, two who are in recovery in Berwick, and I have 4 amazing, beautiful grandchildren who are all pre-genetically disposed to this disease, and I have 2 more on the way. And I'm also a nurse. I've been a nurse for 26 years, and in 2014, my son struggled greatly with substance use disorder, and by January 9th of 2015, he overdosed, and he wanted help desperately. So our experience looked like he overdosed, and when we left the emergency room with instructions to stop using, he told me that, for the past 6 or 7 months, he'd been trying to get help. I was the insurance carrier for our family. I was paying $994 a month. I had an $8,000 deductible. And so I was a nurse, and I had a best friend who was a doctor, and we got on the phone, and I logged 109 hours on my cell phone. It took us 9 days to navigate this system of my private health insurance to get 3 places that he could get treatment, all of which had wait lists. And so, what it looked like for our family was pulling together our personal resources to help him get into treatment in an alternative way. Our lives were restored. At this time, when this was all happening, I was seeing I've been a maternal health child nurse all of my career. And so at this very particular time, while I was going through this with my family, I was having a really hard time getting my pregnant patients and clients into the level of care that they also needed. And it started to become really evident, I watched our family get restored, and I had, distant family members say, well, what's everybody else doing? And it became pretty clear what everyone else was doing is if they didn't have somebody going pretty much crazy and cashing in a 401k at the time, that people were dying, and that was what was happening. So I had a patient come in to see me for her first prenatal at that same time of year in January of 2015. And she was pregnant, and from January of 2015 till June of 2015, she could not get she was on a wait list for the one program in New Hampshire that takes pregnant women. And so she called me the first week of June and said that she was 8 months pregnant, said that she had been outside for 4 days, was soaking wet, hadn't eaten or drank anything, thought she was dying. And I went and picked her up, and she looked like she was dying. I brought her to our local hospital, called my friend who was on call, Opie at the time. She was admitted to the birth center. And she stayed for 2 weeks. Well, we like to call it like a act of Congress. Well, we just called people trying to get her into treatment. We got her into treatment at that point after 2 weeks, which it was like, at this point, it was like all hands on deck. So it was multiple people trying to get this one patient into care. So after she got into care, I really realized, everybody was trying really hard to access the treatment that they needed. It was really hard, and there wasn't enough. And so I probably have an addiction to Facebook, and I put up on Facebook, did anyone know Oprah, Ellen, or somebody rich? Because we needed to do a program for pregnant women, and we needed to do it now, and we needed to do it better, and we needed to take care of these women that were asking for help. And so I'm the program director and co-founder of Hope on Havenhill in Rochester, New Hampshire, which is now in New Hampshire we have 2 residential facilities. We're the only facility on the seacoast, and we serve pregnant women who have a substance use disorder and are pregnant or have newly postpartum, and they are homeless or imminently homeless. We opened in December of 2016, December 8th. We've been full since we opened. And what it looks like for us is that we take care of 8 really brave women, because we're, in general, we're asking people of all walks of substance use disorder to be brave and ask for help, and then, there really is not enough help, right? So it's not super easy. So there's a misconception that, people could get help if they want it. It's not that simple. And so for pregnant women, it's even harder. And so if they need that level of care, it's really difficult, and there's lots of barriers, and they're also looked at as less than even among their peers in addiction. So I watch brave women ask for help and work really hard, to take really good care of themselves and become the moms that they want to be. I watch them work, through a lot of different things and watch things get really well. They watch them get well. So I'm really lucky, because even with my own son, I was really, it was really scary for me. And at the time, I knew people that had recovered from alcoholism. I've known people that have recovered from cocaine abuse, right? But I did not, personally, I did not know somebody that has ever recovered from our heroin addiction. And when he told me that, it took me right to a very scary, scary place where I thought to myself, I don't know if my son will survive. And I'm a mom that loves my children like all other moms do, no matter what. And to me, my children that have a substance use disorder have a disease that needs to be treated. It needs to be treated every day. So as a nurse and as a mom, I was like, all right, let's get to work. But I was lucky very quickly that I had a friend that introduced me and said, I know you're scared, you probably don't think he can be okay, but I heard about this woman who's in long-term recovery from heroin addiction, and she's amazing. And so I was introduced to her, and then I was introduced to this group of people that are, amazing people in recovery. And I was like, okay, so I now have this new goal. I know people that can be amazing people that have this disease, and so fine, we can do this. That's sort of how it evolved for me. So I believe that stigma is a really big part of this problem. And I appreciate your presentation. I do think that the initial picture of the family in the car is really stigmatizing. I know what the reason is behind it isn't trying to be stigmatizing, but I personally, with family members that have overdosed and taking care of moms and children, that have gone through these things, that's out in the web forever, and that's really stigmatizing in general, because it's sort of like, it's like any kind of disease when, we do try to protect people that are either a death picture or not, and that's, kiddos in cars and things like that. That's the only kind of thing that kind of worries me, is that it can be a really, really hard thing to ask for help. And if we can kind of reduce barriers on how to, make people feel less scared to ask for help, it might be really helpful. So that, yeah, that's all I have to say, and I'll take questions after. Sorry, I lied. I am going to introduce Anna Battle, who is a really good friend of mine. She is a person in long-term recovery. She was a recovery support worker in Hope on Havenhill until she had her second little girl, and is a full-time mom right now. And but she is a really great story about recovery, and come on up, Anna.
Okay, hi everyone. My name is Anna. I am a person in long-term recovery, as Carrie said. What that means to me is that I have not found it necessary to use a drink or a drug in under 3 years. My slide about October 20th, 2014 was when the first fentanyl was around here. I went to treatment October 26, 2014. And what I always say to people that I come across who are actively using, it's not the same stuff as it was. It's not the same stuff that I was using. I'm sure I did get a little dabble here and there. So it's terrifying. Most of my childhood friends are dead. My two best girlfriends, we grew up together. We were best friends. We partied together and turned into other things together. And they died 4 years apart from each other, among other countless friends. I have a high school reunion coming up, my 10-year high school reunion, and there's a lot of people that we have a memorial for because they won't be there because they died pretty fresh out of high school. So yeah, this is. I spent most of my life living in Portsmouth. I actually lived in Lawrence for a long time too. My family is many generations in Lawrence, never leave Lawrence kind of thing. I spent my childhood there. I used to ride my rollerblades, Tremont Street. I lived on Bowdoin Street. I would never let my children ride their rollerblades there now, but those were different times, I guess. And I was an IV drug user for many years. And I like to say IV drug user because a lot of people will tell me that you don't look like one. And then I will ask them, what does that look like? And that's where the stigma comes in. That's why that's my main focus of my recovery. So I have a few things that are really personally important to me in my fight to bring light to actual recovery. That is one is the war on drugs and how it is a fail. The second one is stigmatizing of how we teach our children what an addict is or what they look like. And another thing is to help families, especially mothers, because I am a mother of two beautiful children, navigate their way through recovery, because mothers, women usually, but especially mothers, are at the bottom of the totem pole, spit on, looked down on, called worthless, shouldn't have their babies, all these things. I have seen with my own eyes women who have come into a treatment facility, have lost all 6 of their children, and still want to get help because they want to make things better. I did not grow up wanting to be an IV drug user. Heroin is my drug of choice, but I would literally put anything that would get into a needle into my body. I did not, it wasn't a thing for me. I have an internal condition. My internal condition is that I have a need to temporarily escape reality over and over again, all day, every day. I have a need to be able to control and alter the way that my mind works, the way that my moods are. I have the obsession to control it. So my solution to that was substances. Why? Because I found them early, like most of us, and they worked. They worked for a long time. And they started not to work. But by that time, I had kind of lost the choice to use, like whether I was using or not. I kind of lost that. I did not want to do what I was doing. My disease brought me to everywhere I thought I was never going to be. I've been to jail, I've been to prison, I've been to locked wards, I've been to detox, I've been to rehab, I've been under a park bench, and I have been sleeping behind a 7-Eleven. And this was solely so I could get my drug, so I did not feel sick. Now, we talked about the physical symptoms of, we call those sickness, detox, withdrawal, whatever. The worst flu ever, yes, but add on to that, every bone in your legs are broken, but you can't stop moving them. Your brain is on fire, and it is mental torment. Like, that's like the only thing I can think about, because when we get this sick, we know that we need to use, but we can't either can't get it, don't have money, or trying to kick it or anything. We know what's going to make us feel better. We know the only thing that's going to make us feel better is this drug and this needle, and we'll do whatever we can to get it. Does that mean breaking the law? Of course. Does that mean hurting our friends and family? Yeah. Does that mean we're bad people that don't care about anybody? No, we just don't care about ourselves. All we care about is getting well. And for us, getting well is to be like, you were talking about moving forward. So after a while, the high is just being in the middle there. When he moved all the way over there, we call that chasing the dragon. Like, we'll never get that feeling again. But we could try, and we can try, because our brain convinces us that we can try. Maybe we can get there. So I spent years kind of hoping that I would die, but not really doing anything, because of using heavy drugs, but not doing anything to really speed up. I was speeding up the process, but I kind of had this like hope that I would die before, at 25. That was like my magic number for some reason. I did not believe that there was anything like Carrie. Like, I did not believe that there was a future for an IV drug user. Didn't believe it. I was so terrified to draw a sober breath that I didn't even have to give myself a chance to get that, to get that education, that information, or anything. A lot of things that I did were based on fear, doubt, and insecurity, and character defects that just came out in ways like when I use a certain substance, I act a certain way. I can't control what I do when I'm on those substances. Does that excuse my actions? Absolutely not. But this is just the nature of my disease. So I have found that I am unable to take any substance, any amount, at any time in safety. That is my truth. I'm grateful for that. I cannot, when I first got sober, I remember, I can't have a champagne toast at a wedding. First of all, no one was inviting me to weddings at this time. And I was thinking into the future, and I'm like, I don't even like champagne. I don't. But I was worried that like I wasn't going to live a normal life. I'm not normal, and that's okay. Like, that was okay for me. So through recovery and through my own learning about myself and soul searching, I realized, and I know this is actually a theory, Felix called it dislocation theory. So the opposite of the addiction is the connection. So we use because we don't feel connected, right? I didn't feel, and I didn't know this at the time. I was very young, and then I never grew up. I wasn't connected to many as humans, right? People, peers. I was not connected spiritually to anything, and I didn't have much emotional connection. Through no fault of anybody, that's just my disposition. Like I said, I found the cure for that, the temporary cure for that, and that was use substances. Now suddenly, I can talk to people. I can be this person that I kind of want to be. I can change my mood. This drove that. This drove my substance use. That is why I did it. I did not do it to hurt people. I did not really do it to hurt myself, though I probably didn't care. I just wanted to feel okay. And unfortunately, caused a lot of destruction in my life, in my family's life, in my loved ones. I've been around a lot of bad situations. I've seen a lot of death, and lost a lot of people. And if it wasn't for recovery, I would not be standing here. I mean, I definitely wouldn't be standing here. Maybe I'd be in a different room, but I would have been dead by now for sure with the stuff that's up here now and the way that I use. And it's not just the opioids. It was alcohol too. It was methamphetamine. It was cocaine. It was whatever. And when I found treatment, I was resistant to it. Why? Because I was scared. I was defiant. I did not want anybody to tell me what to do. So that window when somebody is like, I need to go to treatment is so small. And our resources are like nothing. Now, fortunately for me, I was under my mother's insurance still. And I got private treatment. I still ran away from those. I ran away from about 6 of them within the course of like 4 or 5 months. Why? Because I couldn't control what was going on and I wanted to feel better. And once you took my drug away, I still had that internal condition, but I had no solution. Even though that was a bad solution, that was still my solution. I had to find a program of recovery to be in place of that. Now, I use a 12-step recovery program. That's what I found has worked best for me. That's what saved my life. I accept all pathways to recovery. I accept everybody who wants help, who does not know how to ask for help. I'll still pick you up. I'll still bring you somewhere. I'll bring you to a meeting or to a recovery center. Because someone did that for me. And did I like it at the time? No. Did I like them at the time? No. Did I want to be there? No. But it planted the seed. So that's what this is about, is kind of planting the seed. Because I would never thought that I would ever be okay with drawing a sober breath. It was terrifying to me. And I was like a real big tough guy, so I never wanted to admit that I was scared, but I was terrified to be sober. When I found recovery, I found that connection. I connected with people that were like me, but wanted better for themselves. I was not used to that either, right? Because I never wanted better for myself. The only thing I wanted for myself was to get more drugs so I could feel okay. When your brain is at one track for years and years, it takes a long time to get out of that. That's the thing where patience comes in. If we have loved ones that are going through this, and I do currently have loved ones going through this, and I have the disease myself, and I still find myself to slip into, why aren't you doing this? Why are you being like? Why are you acting like this? I have to remember where I came from, right? And it should be easier for me, so I can't imagine how it's somebody who does not have the disease. So what I do every day, I'm still a heroin addict, right? That is the word. That is what I introduce myself as in my fellowships. Here I would say I'm in long-term recovery, to stamp out the stigma. I still have this disease. I'll have it for the rest of my life. I have to treat it daily. If I don't treat it daily, bad things will start to happen. My behaviors will start to get wiry. My moods will start to get down. Eventually, I will pick up a drink or a drug. That is the progression of this disease. Is it difficult for me? So basically, how I can sum this up is I spent years and years and years. I mean, I was doing ecstasy at 15 almost daily, and I spent years and years and years doing just drugs, and that's it. And the wake up, the obsession of how I'm going to get the money, how I'm going to get the drugs, that ran my life, and I didn't want to wake up. Whenever I woke up, I was like, oh, I'm still alive, right? Because now I know I have to go, I have to do the hustle, I have to do this. I would drive to Lawrence every day, a couple times a day. Yeah. Today I don't wake up thinking about how to get a drug. Today I don't wake up not thinking about how I'm not going to get a drug today. I don't think about, oh, how am I going to stay away from it today? Oh, how am I going to get it today? It's gone. That obsession is gone from me, and that's because I've worked so hard on a personal program of recovery. Part of that is part of how I stay sober is to help other people stay sober. So by that, like I said, I would pick someone up and bring them to a meeting, or I will work in treatment. I worked at Hope on Havenhill before I had my daughter, and I was pregnant when I was working there, which was interesting. And I was those girls. I just happened to be at a different spot in my journey. And I could look at them every day and say, yeah, I'm you, you are me. And that's what helped me in treatment. I needed a peer. I needed somebody that I knew, that I thought maybe had been through it, but they look like they're kind of on the other side of it, because then I had a little bit of hope. I needed to hear personal stories. I needed to see where people were at, because I was terminally unique, and I felt like nobody had been through what I had been through, right? Turns out a lot of people have. And it turns out the way to kind of treat that is to share our experiences, to share our strengths, and to share our hopes with each other. And it's free treatment, and I do it daily. I speak with sober supports every day, multiple times a day. That's what I've done in my professional career as well. I've worked in treatment. I worked at a different center too, doing outreach, working with families trying to get their loved ones into treatment. And there are things that I did, and I'm a huge supporter of harm reduction, huge supporter of safe injection sites, needle exchanges. This one mother was getting her son and his boyfriend into treatment the next day, and they wanted to stay at their own house, and she said, I know I can't stop them. I said, okay, we'll go over there, give them each a thing of Narcan, and tell them to use one at a time. They're going to do it. They're going to use, maybe if you say that, that'll spark that idea in their head, and maybe they won't die. They didn't. They made it to treatment. They're doing great. These are scary things that we have to say to people, but that's where we're at now in this epidemic. If you're, please don't use alone, or let someone know so they can be on the other side of the door with Narcan. This is the reality. What we can do about it, like we talk about it. Stigma, what Carrie was talking about. Treatment. Because there is treatment. Because I don't stick a needle in my arm 17 times a day anymore, and I did that for years. So there is treatment for this. And the treatment, it starts with the mental health treatment, for sure. This is, like you said, it's a brain disorder. We have to start treating it like it is one. Like we didn't ask for this. Not that excuses actions. We still didn't ask for this, so we still deserve the same treatment that somebody who, maybe have been predisposed to cancer, and a family, a long line of cancer deaths in their family, and then they end up getting cancer, and we don't shun them. Because they certainly didn't ask for it either, right? So, for me, it's important that I share my story, that I don't have to, I'm lucky enough that I don't live in the shame anymore. I lived in the shame for way too long. And my shame came out in anger and defiance and all that gross character defect stuff. But I don't live in that anymore. So when you guys are ready to ask questions, you can ask me whatever you want. You will not scare me. You will not make my jaw drop. I will answer as clearly and honestly as I can. I want to thank Chief Town and Tiffany for calling me. Tiffany called me and it's like, well, what should we say about you? And then he says, I don't want to offend you. I'm like, right, IV drug user, because that's scary to people. And I hope today I don't look like an IV drug user, but I am, right? So let's remember that. That is the disorder that I have. It's not my identity. My recovery is my priority though, but it's not my identity. I am a mother, family member, I do stuff, But that is, it is my life now, but it's on the opposite spectrum. So instead of my life being obsessing about how to get high every day, my life is about having to better myself every day and help others. And I'm not Mother Teresa. We have our ups and downs, right? And that's where our supports fall into place. That's why it's super important to always have good supports. Offer resources to the people where they can find people in your life that are maybe struggling, or if you're struggling, come see me after. I can give you resources where you or your loved ones can find peer supports that are readily available 24/7. It's 2018, we all got cell phones, most of us, and social media and stuff, but there's a lot of groups out there. There's even Facebook support groups that have been really helpful to a lot of people I know. So, like I said, ask any questions after. I think we're taking a break, right? Ask any questions after, and thank you guys for having me.
Thank you very much. Do you want to take 5 minutes, and I'll support it. The public radio has an extensive travel time, so if you have questions that you want to ask of him, so that we can allow him to leave. We'll let you, he's the fresh meat, I guess is how we'll put it. So he's the guy that gets the questions first, and then after that, it's up to you. So go ahead and ask anything you want.
Yes.
Could you speak a little bit on like methadone clinics, if there's any in the area, and how those kind of work?
Okay. Methadone was, I'll just quick, and I won't be quick, because everybody else takes so much time, I don't spend a lot of time. Back in the 60s, there was a major heroin epidemic, and it was characterized by a lot of crime. That was when the streets of major cities were actually burning with crime. And interestingly, Richard Nixon gets elected on the platform of war and crime, gets elected, and the question is, what is he going to do? And somebody brings to him the work of two physicians in New York City who were using methadone at that time to treat opiate addiction. And he opened up, had first methadone clinics opened, and crime rates plummeted. Before buprenorphine came on the market, methadone was the gold standard treatment. Now, I'm going to editorialize a little bit. In a well-known, properly dosed clinic with good treatment, methadone is an excellent treatment for opioids. It's extremely effective, and what you can see in cities that have high rates of HIV or hepatitis C, the conversion rate from a negative to a positive state plummets from about 50% per year to about 3%. So in an era where we're having high rates of bloodborne pathogens and drug overdoses, methadone is an effective treatment. Now we come to Maine. And the problem in Maine is a psychiatrist from Chicago came here in about 2002 and opened up a clinic in Westbrook. And he brought with him a belief that in order to be effective, methadone needed to be dosed in doses of 500 and up to 1,000 milligrams. And he actually, in a crazy way, had an influence not only in other clinics, but actually in the Office of Substance Abuse. He wound up going to prison for 2 years for fraud. After spending $3 million on defending himself. And if you're ever interested, he owned the largest house in Portland, the Seafood Spaces, White House on the Western Front. So one of the problems in Maine is that the reimbursement rates for the clinics here are $63 a week. So if what we know from literature is that a proper dosage, which is probably someplace in the range of 60 to perhaps 100 milligrams a day. In Maine, the dosages are often in the range of 200 milligrams plus. Because of the low reimbursement, substance abuse counseling is very, very scarce and is sometimes non-existent. Consequently, what is the quality of the clinics in Maine in comparison to other places in the country? I just wanted to make the distinction that methadone can be a very effective treatment for opiate addiction. It's got a lot of problems in the state. If you're a fisherman, my practice is made up of lobstermen and fishermen. You don't go to, actually, I have people who had to go from Thomaston or Cushing every day to Waterville to get dosed. You can't support yourself as a lobsterman if you're doing that. So I think that methadone has gotten a limited benefit in this state in terms of Sanford, Waterville, Springvale, Berwick. There are extremely high rates of opiate addiction. In terms of scalability, methadone theoretically would be the best, but I think because of reimbursement, I think because of the way in which dosing has developed and the lack of treatment, finding a way to expand access to buprenorphine would be the best way to respond to the epidemic here.
Okay, me. Dr. Publica. I like the demonstration you did with the swings. And I suppose you could answer this, or Anna can answer this. How does the therapy complement the medication-assisted treatment? How does that help the swings?
Well, if I put somebody on buprenorphine, they're instantly going to stop having that. I mean, literally overnight, in an hour, the withdrawal, the erratic withdrawal. So the withdrawal stops instantly. I mean, I could take somebody who's extremely ill, give them a couple of doses of buprenorphine, an hour or two later, the first thing they're going to say is, I feel normal. Which is really kind of extraordinary. They feel normal. I mean, people who I'm absolutely certain had no concept of what normality was feel normal. Then, what's addiction? Addiction is this profound, powerful compulsion to use a substance and the inability to control its use, loss of control. So you have this powerful demand to use, inability to control the use, leading to use despite escalating personal harm. And that the use happens at the expense of inherently rewarding behavior. So if you ask somebody who's on Suboxone and you feel this overwhelming compulsion to use the medicine, they'll say, no, it doesn't even make sense. You lose control when you take it. Now, somebody who's actively opiate addicted, you give them OxyContin, they're going to use as much as they have. You put somebody on buprenorphine, the question doesn't make sense. No, of course I don't lose control. Does it cause you escalating personal harm in your life? And the answer is no. Of course, my life is getting better, and it isn't preventing you from doing inherently useful things like caring for your children or going hiking. And what they will say is, no, it's allowed me to do that. So then the question is there anything about being on a properly prescribed medication that is inconsistent with people's involvement in 12-step recovery? And the answer clearly is no. If there's nothing. I mean, in fact, my big concern is people getting in 12-step programs rejecting people who are on medication-assisted therapy. It's really a program of acceptance and welcome. It's not one of rejection. People create their own programs. But, my patients who are most successful are the people who are taking the medication and running after 12-step programs, of which I have plenty, and that's what I encourage my patients to do. So what does buprenorphine does? It stops that. It stops that. It allows you to be here. If you're here, then you can stay focused and you can work on your recovery program.
More receptive to it?
I'm sorry?
More receptive to it?
Able to.
And you agree?
Yeah, I agree. Especially for me, my own personal experience with it has been mostly in a detox setting. There was, to get over that insurance 5 to 7 days, of course it's more than that for the post-acute withdrawal symptoms, but to get over that hump to where I could be willing to take a suggestion, start a treatment program, to where I can kind of stabilize my mood. I needed the buprenorphine and the other medications during that detox process so I could, for lack of a better word, be clear-headed, because I believe, for myself, I know without having a clear head, there's absolutely no way that like I said before, I'm one-tracked on getting the drug, going to sleep, waking up, and getting it again, Groundhog Day. So if we take away that compulsion and the craving, which the buprenorphine absolutely does, then I can start to work on a program where I don't need to use it. Eventually, I don't need to use any substance. But you got to get there first. This is not an overnight process. We didn't get like this overnight. We're not going to fix it overnight.
Thanks.
I have a question. You stated that if marijuana was presumed to be the gateway drug that leads to other drugs, how harmful or likely is vaping, which is a very new and attractive habit to youngsters, middle school, 11 to 14-year-olds? How harmful is vaping? Is that kind of gateway into other areas as well?
So 2 questions. I guess the question is nicotine a gateway drug? And the answer is, yeah, absolutely. If you can have somebody not begin smoking cigarettes until they're after 2021, it's less likely they're going to develop a substance abuse problem. The issue with vaping, the issue with nicotine is that, again, the earlier the exposure, the more, the term is plastic. You know, you think about plasticity. What's plasticity? It's moldable. Well, the moldability of the adolescent brain is really greater than that of the adult brain. And things that can change it in a way that wouldn't change an adult brain can really direct it in a way towards long-term dependence. You know, those of us who started smoking cigarettes when we were 15 are going to struggle. You know, even if we don't smoke, I'm 68, I quit in 1975, I started at 15. I can still get triggered. You know, I'm never going to pick up a cigarette again because I know it would kill me. Actually, my wife would kill me. So is vaping bad? Yes, vaping is bad. Again, it's affecting brain function. It's leading to changes in the brain that are going to predict lifelong problems with abstaining from vaping. It's a lie that Big Tobacco is very happy to promote, that vaping is safer than smoking, because what they're doing is creating a population of young people, of course, who are going to smoke cigarettes.
Right. And I think there's a misconception too with those vapors that, you know, kids are under the impression that there's no nicotine involved, it's just juice. You know, and it's like the education at that level has got to be.
There's one other issue. The issue is that these are substances in the vapes that are not meant to be inhaled deeply into the lung. Depending on the heat of the filament, formaldehyde is formed. So, you know, and especially if there are flavoring item colors in there, those are breathed deeply into the lung. They're never meant to go in there, so they're harmful to the lung function. So, vapes are bad.
So these young kids that are doing it are unwittingly knowing that they're just leading on to other.
Well, I mean, think about Joe Tobacco, Joe Camel. Think about everything else. The tobacco companies paid huge penalties for advertising to children, and essentially what they're doing is a backdoor for vaping for children. So I think it's the same thing.
Not to chime in on or ride on your coattail, but the marketing it's not novel. It's been going on, as you said, from the Joe Camel era. But every street drug that comes out that they package in some other way, like bath salts, or any of these circumstances, if you look at them, are artificial marijuana. They're cartoon-like, they're colorful, right? And it's enticing. And then always the default when you talk to folks who come in who are young, they're like, oh, it's not the real stuff. And it's not as bad, or for whatever, or there's not enough data. You know, people will come in all webbed up as far as what information, and it's a little of this and a little of that, which will refute anything you try to say because they're legitimizing it. And if it's legal, meaning they just bought it at the local head shop, and it's still being sold, then how do you say, you know, you shouldn't be doing it?
Right. I just don't understand how they can't sell it to an 18-year-old. I mean, you can't sell it to these younger kids, but they can have it. It's like, what? That's just a double idiom for me. Okay. You answered my question very well. Thank you very much.
You've all touched on it. Some of you have included it in your title. Hope on Havenhill. But you've done this for 36 years. How have you personally held on to hope? All of you have continued in your fields when you could have gone into a less adrenaline pumping medical career, less ramped up three-letter initial. I mean, how do you personally hold on to hope? Because it's hard. It's hard not to become cynical. It's hard not to.
Who's holding on to hope? The practitioner,
all of you,
the family,
all of you.
Oh,
I worked in medical oncology, so I had to wrestle with that. How do I go in and treat?
I get hope because I have got the best field in medicine, because I get to see people who are destroyed mentally, physically, spiritually, and become wonderful human beings. I mean, if somebody had met her how many years ago?
3 years ago.
Yeah, I mean, the person who was involved in treating her has witnessed this wonderful reinforcing thing. You get hope from that. You know, for me, it was when I started treating discovered alcoholism in 1983 in Pittsburgh. I had no knowledge or thought about alcohol, and I started to try to explain this to my patients and go to some meetings with them. 6 months later, I started to get God bless you letters, and I was thinking, boy, diabetics don't do that. That began to give me hope. You can actually sit down and work with somebody who's got this devastating, life-threatening disease and see them get better. So, diabetic, I can get you under good glucose control, but you still may be a jerk, right? If I treat you for addiction, you can become this wonderful citizen. Honestly, the people that I know in recovery are better human beings than people who have never really suffered the disease. So that gives hope. Far more people get well than don't.
I'm exposed to the nasties of the world, the devils, day in and day out. But I step outside of that and I see sports teams and watch my children grow up and the neighbors, and you don't want them to ever cross that path. And that gives me the internal energy to keep the drive, keep the energy, stay focused, motivated, because I don't want that systematic devil to ever come into my community world. And just keep driving forward, and you basically bring out the energies to others and expand the team. And the team is community, which is what you're doing here.
I remind myself not to forget, and I think that Anna kind of mentioned that, which is, when you are really at the end of whatever lack of whatever minute part of empathy at that moment, or why am I still doing this and I'm on X number of days, clinical shifts or whatnot, try to remember how I got there, that I don't like what I do, that I love what I do, to take a step back, and also, quite frankly, over time, because everybody, I think your level of tolerance or threshold changes as you do anything, whether you're a journeyman or a physician or whatever you do, and after a while, you don't have the same energy and the same ability to hang in. But when I'm part of these impromptu circumstances and around people of all different generations with all different experiences and backgrounds, it helps me, one, remember how I got to where I am now, and I had to claw my way into becoming a doc, and I love it. And also to hopefully have the energy around me from everybody, like what you just said, and from different perspectives, to say, this is how we all carry it together. And I don't have to have the same energy. Hopefully I'm around more and more of this, and even my day-to-day, where the energy keeps carrying that peer-to-peer recovery, and using the right terms and changing how we all do it together. And then you don't have to keep reminding yourself so much, because it's done collectively.
Just one thing, because you have a very special circumstance. There's a chapter of a book that which talks about hope. Now, it's hope not in a soft, crystal holding way, but it's looking at hope as will, hope as horizon. If you give me, it's from a book called Integrating Spirituality and Practice. But if you give me a card or your number, I will copy the chapter, which is like a chapter, but I'll copy it and send it to you, because it's really worth reading this chapter about hope.
It's pretty easy for me, because I get to watch really broken women who are really, really brave every single day walk through the doors, and I watch them, get well, and I watch them be amazing mothers that they wanted to be. So I watch babies thrive, and personally, I get to watch my family, be well. So,
I realize I have to make one correction on the introduction. Mercy Hospital closed the Recovery Center in 2015. So there is no Mercy Hospital Recovery Center, right? At the kind of peaking addiction, biggest treatment program closed. So I was thrust out into the world without a job, and I didn't want to be a pen just writing prescriptions for people working for clinics. So I'm in private practice of addiction medicine.
So, I believe, to keep up hope, I can watch the person that I was, I kind of think of it visually as like a big black wall of the person that I was before and the person that I am now. So that gives me hope, but more importantly, working with others gives me hope, like what Carrie was saying. Like one of the first residents of Hope on Havenhill, just recently, a few months ago, was completely reunified with her daughter that she lost when she was 2 months old, and like that, like I could get emotional about that because that's what it's about, because it does happen. And it's important that we tell people that this does happen, and that's how I can keep up hope for sure. And it's an everyday thing, you know. I have family members too, and I watch my family members as well. My dad hasn't had a drink since 1996, and that's a long time, right?
I have one other question. With fentanyl being such a dangerous drug that it is, can it be found on everyday public places such as shopping carts or those handheld baskets that you walk around with? Or what other places in public can you need to be cautious of, or that can be dangerous places just from somebody who maybe has manufactured it somewhere, or...
I just have to answer that. My wife works in the National Library of Medicine and Toxicology Division. It's exaggerated.
Okay, all right, no, I just...
I mean, it isn't as though if you touch some white substance and it might be fentanyl, you're going to die of an overdose. So I think that, you know, there are situations with law enforcement where they may come in contact with high concentrations, but even in those cases, you know, they don't need to go into hazmat suits if they're making a bust. So I think that fear is probably...
It's more of a myth than...
Yeah. I'd be concerned about car fentanyl, quite frankly, because that's where we get the literature for overdoses is from veterinarians and animal parks who accidentally get fentanyl on them. Car fentanyl.
You're walking into a hotel room where they're actually packaging it, you gotta have concerns. You know, I get a call over the weekend from the Cumberland County Sheriff's Office that a defendant had dropped a bag with fentanyl onto the floor. What do? They sent people for exposure to the hospital. Just because it was on the floor, somebody in the room, I wouldn't be too worried about exposure. Mopping it up, dissolving it, throwing out the sponge and all that, I think would be sufficient at that point. Deodorizing the floor. You know, most of the testing shows that it's in the 1% range, but there's that anomaly where you could have a higher dosage. You see white powder, just use common sense.
Mike, you said there's no heroin in Maine. Is that literally, or just it's been supplanted by fentanyl for the most part?
Fentanyl has really supplanted it. The Mexican cartels are distributing, they're bringing fentanyl because it's a smaller object that can create a larger profit margin for them. So they can bring that much more. Their heroin will pop up from time to time, but from a general standpoint, what we're seeing, what our state and local counterparts are seeing, what we tested, it's fentanyl. And when the lab results come back, it's fentanyl.
Because Dr. Cohn says he had 60-year-old heroin addicts that have been on it for decades. So there must be the same people in Maine as well that have to get access to heroin, I would think.
That's correct.
New Hampshire, it's
Fentanyl does the job.
It isn't as though one heroin addicted, suddenly you have to find heroin.
But the supply chain coming through is not supplying heroin, it's bringing fentanyl.
I actually had that down in fentanyl versus heroin. Fentanyl is a synthetic heroin, is that what it is?
Well, heroin is synthetic too. You know, the benefit for the cartels, I think Michael would agree, is that if you're a cartel and you're making heroin, you need peasants in the mountains growing poppies. Then you need mules to carry the poppies down to the bricks and mortar factory where you have employees. You know, presumably you're paying health insurance for something. And then you've got to import it. But if you're using fentanyl, you've got the precursor. You don't need peasants. You don't need mules. You don't need any big bricks and mortar factories. So for the Mexican cartels, you know, fentanyl is cheaper and is a much easier and better product. Is that a fair way of putting it?
I don't know if Mike can support this, but another thing is prior than just about the part where you can really increase your profit margins and how smaller amounts then can be brought over. Up until recently, many labs, including many hospitals that are not set up for that, couldn't test for the fentanyl. So you'll have people overdose, you dead in overdose, and you'll send off a drug screen, and for an opiate panel, they'll all be negative as far as the lab's capability, because it won't test for it. And the fascinating part about that is the cartels took advantage of that as well from a distribution standpoint, because if you have laws set up to test for heroin or to bust people for heroin, and then all the associated crime with that, but it's not heroin, and there's no law in place for it, and or you can't test to it, and then once you finally do test it, the laws are lagging how do you prosecute for it, you just get a larger opportunity to capitalize on pushing fentanyl and getting away with it.
Well, one of the scary things is the cartels don't make oxycodone. It's expensive. But with pill presses, they are making fentanyls that look precisely like oxys. So, now we have this population of Mainers who have had their prescription doses forced down from whatever they were on down to below, say, 50 milligrams or lower of oxycodone. People are going to turn to the streets. When they turn to the streets and are buying what they believe are illicit oxycodone, they're at really great risk of, in fact, instead using fentanyl tablets that look like oxycodone. So the risk of overdoses for that population is great. We're not even talking about a population of people who we would normally define as drug addicted. Your relative who has severe hip arthritis, whose doctor forced them to go from 150 down to 40 milligrams of oxycodone, and somebody finds some extra oxycodone, but it turns out to be fentanyl, you have dead grandma.
Like late 2014, 2015, when fentanyl first came into this area, the cartels didn't know how to properly package it, and it was packaged in higher dosage units, which is what caused a higher propensity for overdose deaths. The last thing they want to do is kill their customer base, because then they don't have the profit margin. So then the dosing went down, and through time, got to a point that was stabilized. But again, somebody who has not been dosing with something that's that lethal, suddenly injects it, your body can't take it. It goes to cardiac arrest.
Also, a lot of people who have had periods of sobriety in between the time that if the fentanyl did come around, who would have a reoccurrence, use again. Usually it's the one and only time because they die. I mean, I've known just in the past 3 years, plenty of people who had sufficient time in sobriety, unfortunately went back to using and didn't even get a chance to walk back into a treatment center, to walk back into a recovery center or a meeting or anything because they died right then. And everyone's like, how did that happen? Because it's absolutely not what they were used to, and they think they can do the same amount as when they had a finger a day habit. And they think they could do the same amount in one shot, or it's a completely different product.
It's one of the reasons why, speaking who have not used, we have to solve the problem of what to do with people who are incarcerated. People who are on methadone or buprenorphine prior to going into prison, who are forced into withdrawal. There's actually a U.S. attorney of all things. The DOJ is actually putting prison systems on notice now that it's a violation of the ADA for them to deny people. It's coming from the U.S. attorney in Boston. It was the DOJ process that kind of shocked me. But prisoners leaving jail who are opiate naive, that is, if they weren't using in jail, have this rate of overdose deaths that's over 100 times that of the general population. So people need to be started on medication, whatever the medication is, prior to discharge. Connections have to be made into the community for continued treatment, because guess what? If you don't treat people who have histories of drug addiction and their crimes were drug related, then you are going to have a process of recidivism. You really have to do and treat people. And I have a lot of people in my practice who have been incarcerated, and they're not antisocial. These are people who, in the course of their addiction, performed antisocial acts. And it doesn't predict that they're going to be antisocial when they get clean and sober, get themselves in a program and are clean.
Chief Towns, what would be the one thing you would want people in the community to do that would be the biggest?
I think the community really doesn't grasp what the effect is on we'll just talk about Berwick for a minute, just here. The idea for me to bring this into the classroom came from myself and my detective going into a home here in Berwick. And it was that family's second overdose death. And you're staying in a home, and you can look where there's a bedroom that used to be occupied, and now there's going to be another bedroom that's not going to be occupied. And at that point, I'd seen the progression in Berwick go from when I first started here, we heard of heroin. You heard of heroin was something that was away. And I saw the progression literally sweep this community. And everything you've heard, we've seen right here. I mean, you've gone into houses where, you're finding somebody that had no opportunity. They literally have the needle still in their arm, and they die that quickly from some of the stuff that they're getting on the street. We've heard through body wires, we've heard deals going where they're selling this stuff, and they're telling me what they call friends. Will you call me tomorrow so I know you're still alive? We actually hear that stuff. So the reality is, it's here, and I think the community has to get a grasp that it touches the entire community. It isn't just a group of people. It has an effect on the entire community. We're fortunate we have a full-time fire department that uses Narcan. We have some resources that other communities our size don't have. But if I had to say that there's something that we really need, we have no place to send these people. We're seeing the same individuals sometimes, literally. We've seen them Narcan, go to the hospital, come back, and we have to do it again all within a 24-hour period. That's all the stuff you hear is a reality that we see here. The day tripping, almost all of the drug cases that we have dealt with are people that are literally going back and forth to Lawrence 5-10 times a day, some of them. And that's basically, it isn't really for these people profit, it's to support their habit. That's how far into it they are and how they really have no control. You've heard, I think the term was, it's like a train with no brakes. They can't stop. I've seen kids that literally, when I first started, I see them playing like Little League sports, and then I have a conversation with them 15 years later, and they're telling me, you have no idea how much heroin is in Berwick. And they have no place to go. And this individual is saying, I know what's going to happen to me. I'm going to the hospital, and I'm going to get released. And when I get out, I'm going to go find some more heroin. At the time it was heroin. We've seen the progression. I don't think we've tested heroin here in Berwick for probably a year now. Everything is fentanyl. And we're constantly trying to catch up with what's going on. Our resources are what they are. We're a small community. We have a relatively small police department. So I'm looking for help from the community. This is kind of like phase one to let the community have some idea of what we have for a problem. Phase two, in 2 weeks, I'm inviting anybody that's here to come back. And we're going to talk more about kind of like what I just did here, a little more about the focus on Berwick and maybe how the community can step up to the plate. And maybe go to bat and find some places for these people to go. She's a success story, and I see people on the other side of that where desperately want to get to where she is. And a lot of them just don't have the resources to get there. We just don't have it. Does that answer your question? I know these individuals, we've gone over it, and I appreciate your time, and I apologize for the length of it. I'm going to have to squelch some of the questions so that...
I can stay, so I'll stay over. Anyone that wants to ask any questions personally.
Awesome. But it's an open invitation. If you want to stay, that's fine. And I understand if you need to leave, that's fine too.
I need a police escort to get me.
Let's go. Thank you very much.
Thank you.
My question is for Carrie and Anna. It's the same question, but Carrie, as a parent looking back on your boy, and Anna, as a young teenager, looking back on maybe something your parents could have done for my 17-year-old. Like, so, you know, your kids were on the right track and they were good kids and, you know, doing the right things and the right home and your parents were together and, you know, they were not divorced and the home was, you know, not a broken home. So, you know, things like that. Aside from threatening his life on a regular basis and things like that, you know, and I can't follow him around anymore because he won't let me, you know, what more possibly, because let me give you a situation. An example of the situation is since they legalized marijuana as medically necessary, he was at a friend's house maybe a year ago, and the parents had made brownies. And he's completely oblivious to the whole marijuana brownie thing, and didn't have any. I'm pretty sure he didn't have any, but he had told me about it either the next day or whatever. And I just, had he not known, he would have partake of the brownies and.
Well, honestly, my kids would have just eaten the pan. So like, so I did, you know, I went to church with my kids. I was on the PTO. You know, we were very involved parents. And I'm a nurse, and I knew that I had a family history. You know, my dad had alcoholism. I was a women's health practitioner, so I talked about birth control and drugs all the time.
Right.
And all of the time. And you know, 2 out of 3 of my kids did everything. They just did. So they did them. We talked about it. We punished them. We did everything we possibly could. And in my opinion, this is my personal opinion, alcohol and marijuana it affects their brains, and they were looking for, you know, they were doing it recreationally, they liked the way it felt, they were trying to fill something that didn't feel good about them for sure, and it progressed, and it was a little train. I watched trains crashing, and, you know, I just had to. It wasn't good.
I mean, I know that, you know, we have to, but I certainly wasn't prepared to have that conversation with him because I really hadn't thought about how something like that would affect him going over a friend's house. I mean,
I would worry about it because I talked often about, I said this isn't okay for
I
marijuana.
hadn't played that out, and certainly.
I think it is going to be an effect. I think it's going to be a problem for kids because just like big tobacco and the vaping, I think the legal marijuana will be a problem for kids. I think it's going to be an issue. So.
It's a huge cultural change, and it's not just the marijuana 20 years ago. And those brownies are not necessarily just the plant being mixed, it's the high THC extract that's being pressurized out of the plant into a liquid form and then placed into the brownies as a substitute for liquid oil.
Right. But like, you know, you hold the parents responsible because if my son had partake. You know what I'm saying?
No.
I mean, then.
No. No. And.
Well, if the parent made the brownies for the kids.
That parent. I thought you were talking about my parents.
I'd be like, yeah.
Do they make them for the kids or do they make them for themselves?
Yeah.
Because what do we say? Because a lot of, I know when I was growing up, my friends' parents drank, my mom drank. What's the difference, right? Because not everybody has the disease of substance use disorder. So not everybody is going to be, look at the pan of brownies and say, I need to eat all of those right now. How can I sneak down here and steal this whole pan and be obsessing about it all night? Because that's what I would have done, or her kids would have done. My parents, I had a great, normal family. I'm the youngest of 5. Irish-Polish family, they're all from Massachusetts. We had a huge family, a lot of family gatherings. I've had an uncle die of alcoholism. I've had 2 cousins die of overdoses. One's in treatment right now because he just overdosed. Not because we had a bad family or not because my parents didn't care. I think that personally I felt a lot of shame because it is a shameful thing, right? There's plenty of kids that I partied with all through high school and even after high school who have PhDs now. And they were doing what, I mean, they weren't shooting heroin, but like it's not, we're not gonna, for me, like I'm not gonna say that everybody who picks up a cigarette or everybody who smokes marijuana or drinks a beer is gonna end up under a bridge with a needle. So that's really important to think because then that causes mass hysteria and fear, and then that's where the shame comes from, and the shame that we with the disorder feel not wanting to be honest. And I think that what I could have done. What would have been cool for me if I had even known it was a problem, it was so normal to me for some reason, I think it's just because I felt so good. If I knew it was a problem back then and I was able to like voice it the way that I can voice, you know, what the disorder is now, had I been introduced to people in long-term recovery, had I been like, that's cool, you know, like that's what I want to be, that's what I strive, because I had lost all motivation to do anything. I didn't want to go to college. I didn't want to do anything to better my life. I just wanted to stay immature and like in this bubble of using. And for a lot of those kids that I partied with, a lot of them are dead. But a lot of them have master's degrees, PhDs, their own houses, all this stuff. Because some of them just didn't have the disorder. So they didn't. Maybe they would party on a Saturday night, but Sunday morning, you know, they were laying in bed and eating breakfast and, you know, nursing a hangover, while us, you know, me or Carrie's children were Sunday morning looking to do that again right now. So that's the difference. And I think it's important not to cause the mass fear or mass hysteria of if my child, maybe if he, because we don't know. And unfortunately, we don't know. But I mean, you can tell a lot in behaviors. A big thing is being dishonest. And I know that's kind of a trait of a teenager or a child or anything. But being dishonest and hiding things, that's kind of a red flag. And I guess maybe making a relationship where your child completely trusts that you're not going to judge them for what's going on in their life and what they're dealing with emotionally and everything. We all know that we've all been teens, right? We all know that the teen years are a really nutty time, for lack of a better word. And you put drugs and alcohol on top of that, and like the doctors here could say that really alters your brain. So if we kind of nip that in the bud and be like, we could talk about this. Why do you think you feel like this? Do you think you feel like this because you're not connected to something? Can we get you connected to something? I mean, because I didn't know that until I got sober, and my parents sure didn't know that either. So that's super important, but absolutely not causing the mass fear or hysteria.
That it? Thank you very much.